We present a modification in the standard macular hole surgery where macular hole closure can be achieved without gas tamponade or prone positioning postoperatively. We have no financial interest in the subject matter of this presentation. Our technique involves mechanically closing the macular defect using a macular plug, which is made up of multiple layers of inverted internal limiting membrane flap sandwiched between two layers of autologous gluconated blood clumps. As the internal limiting membrane is held in place by the sticky autologous gluconated blood clumps, the need for gas tamponade to keep the hole dry is rendered unnecessary and the patient is spared of the cumbersome postoperative positioning and the complications associated with gas tamponade. The anatomical and functional results in our series of cases has also been very satisfactory. Our first patient is a 62-year-old pseudophakic with a stage 3 full thickness macular hole with a mean base diameter of 1472 micron. The initial steps of the surgical procedure are similar to a standard macular hole surgery and involves a co-vitrectomy after triamcinolone acetonide assisted posterior vitreous detachment induction. The internal limiting membrane is stained with brilliant blue G and macular rhexis is initiated with a Finney flex loop. A broad area of internal limiting membrane peeling is performed to relieve any tangential traction on the hole. The internal limiting membrane flap is inverted and reposited into the hole. And laid over with autologous gluconated blood clumps. The preoperative OCT image shows a large stage 3 macular hole with a mean base diameter of 1472 micrometer. On the first postoperative day, we can see a loose plug in the well of the hole bridging the edges. A well-formed tissue plug with partial restoration of the outer retinal layers is observed by the day 7 and by the 14th postoperative day, restoration of the outer retinal integrity is complete, with an improvement in the best corrected visual acuity from a preoperative vision of 5/60 to 6/9. In this patient with a stage 2 full thickness macular hole with a mean base diameter of 1204 micrometer, we demonstrate the use of autologous gluconated blood clumps for all the steps of the surgical procedure. Autologous gluconated blood clumps is used to delineate the posterior hyaloid face to induce a posterior vitreous detachment with the suction of a 23 gauge cutter. Blood fills up the well of the hole and forms the first layer of the macular plug. A tear is initiated in the autologous gluconated blood clump stained internal limiting membrane using a Finney flex loop, and the ILM is peeled to the margin of the hole. ILM stained with autologous gluconated blood clumps is sticky and can be easily reposited into the hole and laid over with blood. This is the serial OCT follow-up pictures of the patient taken on day 1, 7 and 30, showing adequate hole closure with excessive proliferation of the macular plug. During the procedure, great care is taken to prevent the internal limiting membrane flap from getting detached from the margin of the hole. We were not really sure whether an unhinged flap would serve the same purpose of acting as a scaffold for migration of tissue into the hole. In the next video clip, we will demonstrate how a detached internal limiting membrane flap can be converted into a free autologous ILM graft to fashion the 3-layered macular plug and achieve hole closure. After a standard pars plana vitrectomy, triamcinolone assisted posterior vitreous detachment induction, brilliant blue G staining and harvesting of a large internal limiting membrane flap was performed. As the flap was too large, we attempted to trim it down with a 23 gauge vitrectomy cutter. The flap gets detached from the edges of the hole. The dislodged flap was then gently brought to the hole and stuffed into it, laid over with autologous gluconated blood clumps to complete the macular plug. Hole closure in this patient occurred by the 14th postoperative day. Analysis of the OCT findings showed that apposition of the inner retinal layer superior and inferior to the center of the fovea occurred by the first postoperative day, while restoration of the outer retinal integrity was achieved in all our patients by the 30th postoperative day. The hole closure occurred from the inner retinal layers to the outer retinal layers. Thus, 23 gauge pars plana vitrectomy combined with the broad internal limiting membrane peeling, use of inverted internal limiting membrane flap repositioning, and autologous gluconated blood clumps as a macular plug is very effective in achieving satisfactory hole closure with significant functional improvement for large stage 3 and 4 macular holes. We were fortunate to have this work published in 2017 in the March issue of the Retina Journal.